are recording, and we are having some participants join us on the 3 o'clock hour. I will allow Dr. Harman to introduce Dr. Garza in just a few moments, but as people join us, and I will do this again at the end, I will also share, if you are interested at the end of this call to ask more questions, then I would be so happy to book time with me. So you can do that by heading on to talk to a PSC expert. And then you will see I have availability and a calendar appointments as early as 9:15 tomorrow, Pacific time. And so I would be so happy to answer any questions. If you're interested, you can also download our ebook. I will send that to everyone. I'll also send a recording at the end of this call there as well. And if you're interested more in cell banking, you can also go in here and understand more about the STEM Preserve and STEM Ready programs there as well. And again, we'll reiterate that at the end. We are at 3:01 Pacific time. I certainly respect everyone's time and thank you for joining. I will hand it over to Dr. Harman, who will introduce our newest advisor to personalized stem cells, somebody who we are very excited about having. And he will introduce Dr. Jaime Garza and explain a little bit of why he's joining PSC.
Excellent. And also at the bottom of your screen, there's a little Q&A button. And so we will be watching, including Dr. Rogers and I, who are going to try to moderate the questions and catch them as they come in. And we can answer some of them on the way. The plan tonight is not to be an hour-long lecture, to be short and to be lots of back and forth discussions about stem cells, because there are many, many questions out there, lots of mythologies, and this is going to be an interesting evening. I am privileged to say Dr. Jaime Garza is a friend and a colleague for over a decade now. He's an MD, D.D.S, and a fellow of the American College of Surgeons. But more importantly, he is an amazing blend of an academic surgeon, a clinician scientist, means he puts on the white coat and takes care of patients, at the same time thinks about science experiments. He's an innovator with patents, but maybe really most importantly for tonight, he's a two-time Tulane Hall of Fame career wide receiver. And I think, and I've watched, that's driven his career, his professional career, in the service of patients and athletes. And I think that's hugely important, especially for tonight where we're talking about athletes and their needs. He has a really long list of accolades, but I think importantly, he's Professor Emeritus of Surgery at University of Texas Health, a huge group. He's a clinical professor of orthopedic surgery at Tulane, where he spends a week every month training residents and trying to bring them into some modern medicine techniques. He's the director of human clinical trials there at Tulane University as well. President of the Texas Center for Cell Therapy and Research at the Texas Center for Athletes, very important. He's also a senior medical advisor for the NFL Alumni Association, Alumni Health Association. I'm sure he'll talk about that a bit tonight and why he did that. He's a multi-time published author in journals like the American Journal of Sports Medicine, which is really important that you take what you know, what you find in the clinics, and get it published. And for us at PSC, really importantly, he was recently appointed our senior strategic advisor. And so helping us understand and navigate academic medicine, clinical medicine, and athletic medicine. With us tonight is also Dr. Chris Rogers. He is our medical director of now almost 9 years at PSC. He is also a practicing physician most importantly for us in regenerative medicine. More than a decade we've been doing regenerative medicine together and orthobiologics. He's here in San Diego, and he heads up our medical program here. So Dr. Garza, I'm going to turn it over to you. Bounce any questions back and forth. We'll look at questions coming in, and so we may slow you down for a moment to answer some of those questions. But bring us into the 21st century with your view of regenerative medicine and how it applies in athletics.
Oh, thanks, Bob. Thank y'all so much, and you too, Chris. And thanks to Corbin and Lance for getting this organized. I am appreciative of being on this panel. And if I can just figure out how to share my screen, I'll get started in a second. I think the plan for me is to I've got a series of slides, and I'll probably be saying things that some people think may be over their heads, and some people in the audience may think, man, he's talking down to us. Um, I'm trying to keep this at a layman's level so that most of the members of the audience can understand what's going on. But suffice it to say that maybe 7 years ago, I'm a member of the NFL Alumni Association, and we get frequent emails from our leadership about different options that are available for us, uh, health options, disability options, job opportunities, that sort of stuff. Sort of caring for our own is one of the tenets of our mission statement. Surprisingly, I started getting emails from the association about stem cell treatments that were available to us. And being in the space, I've been a stem cell researcher probably for about 20 years now. I started at the University of Pittsburgh, it was close to 30 years ago. Um, and I had some questions for our leadership because what was being offered was really just bunk. It wasn't real, it wasn't stem cell treatments, and essentially people were taking advantage of the NFL alumni. Everybody wants a piece of that shield on their website. And I think part of the give and take was we'll treat a couple of your members for free, and you guys let us use your NFL Shield on our website. That's $2 million worth of advertising. So suffice it to say that the discussions began, and we actually, under the leadership of Kyle Richardson and Billy Davis at NFL Alumni Health, they started NFL Alumni Health as a subsidiary of NFL Alumni. And really, what the focus of NFL Alumni Health is really to screen out all these different treatment options, things that are being offered to us, medications, creams to ease the pain. And I think we've done a very good job over the last 6 years of honing this in. So I really want to talk about the work that Dr. Harman's done. As he said, I met him 10 years ago, and Dr. Rogers as well. Let me share this screen and let me get started. But so I was asked to speak about advances in athlete recovery. And this is really an overview of stem cell treatments. And what my plan is to discuss a little bit about what stem cells are, what stem cells aren't, and really focus in on what personalized stem cells, or PSC, is doing um, in this field. You guys saw and heard from Bob already what's going on with me, but the important thing is Dr. Bob Harman is the CEO of this company. He's also the CEO of VetStem, and I'll touch on that in a little bit. Dr. Harman, by training, is a veterinarian, and he has, over the last almost 26 years, treated over 30,000 domestic and exotic animals with greater than 50 medical conditions with this very technique. He is the Chief Executive Officer of Personalized Stem Cells, or PSC, and he really, truly is the world's leading pioneer in veterinary and now human mesenchymal stem cell therapy. I'm really honored to be on this panel with him. He was one of the first to conduct FDA-approved trials of stem cell therapy in humans and in animals. Dr. Rogers, fantastic physical medicine and rehab physician. He's the founder of the San Diego Orthobiologics. He's also co-founder, interestingly enough, of Data Biologics, which we'll discuss in a little bit. But he is actually gathering data with his colleagues across the country and across the world on all these different types of treatments and really what the outcomes are. This is really about real world data and real world treatments. There's no hocus pocus involved in this company, and that's why I'm here today. So what are stem cells? We've heard it over and over again. Stem cells are basically the body's natural repair cells, and they can become anything. Mesenchymal stem cells can become cartilage, bone, tendon, or muscle. How do they work? Most importantly for us as patients and as physicians, stem cells essentially reduce inflammation They immunomodulate. They wipe out or decrease the amount of inflammation in a particular structure, where it's a joint or a tendon, soft tissue, and they release signals or signaling particles that go out into the human body that lay down the framework for healing pathways so that the body can start to heal itself. Really important work. Mesenchymal stem cells, this is a blood vessel here on the right side of the screen. This thing intimately attached to it, looks like an alien, is a stem cell. They reside in what's called a perivascular niche. They're essentially found in almost all tissues in the human body. Essentially, when I did a lot of burn work, I harvest a skin graft off one part of the body and put it over a burn to help it heal. Well, theoretically, I could say I was putting a stem cell graft on that patient because skin also contains stem cells. But it's the quantity of stem cells in any particular tissue that makes the difference. These cells are able to self-renew and they promote tissue regeneration. It's really, really important. They're found in adipose, which is fat. They're found in bone marrow. And they're found, I think a lot of you heard about umbilical cord blood cells, umbilical Wharton's jelly, and we'll talk about that in a little bit. So what are not stem cells? And these are words that anybody who's in the orthopedic world or has musculoskeletal problems, has gone for treatment, has heard. Exosomes, that's the newest buzzword. Exosomes are real. They're part of stem cells. Unfortunately, they're not proven to do a whole lot just yet. PRP, probably one of the most common things used to inject into a joint now. This is not stem cells, and it contains no stem cells. Umbilical cord cells, again, very, very few stem cells are found in this, although you do find some. There's not that many. Stromal vascular fraction, that's a space that I've worked in for the last 20 years. And this is essentially that perivascular niche where those stem cells reside. And we're able to separate those from the tissue. But instead of just isolating the stem cells, we get a whole group of cells surrounding these stem cells. So in the stromal vascular fraction, and it's been studied very well, you can find somewhere between 5 to 15% of those cells that are actually stem cells. And then bone marrow aspirate or BMAC, again, contains stem cells, but very few when you compare it to adipose tissue. What are stem cells? These culture expanded mesenchymal stem cells is what we're talking about. That is PSC's and Vet-Stem's business. They're able to isolate the stem cells from this perivascular niche, from the rest of the stromal vascular fraction. They plate them in a GMP facility, which is essentially as high a quality as you can get for sterility and FDA approved. Culture expanded mesenchymal stem cells, you can get billions of cells. This is what's used by personalized stem cells, and this is an area that's tightly controlled by the FDA. So the FDA has incredible oversight over this field. They regulate the safety of these cells, the safety of the manufacturers, the safety of the physician's office, the sterility of the product, how these are processed. And they also have oversight in the clinical trials that most of us are overseeing. The FDA has real concerns, and you read about this all the time. I mean, I think this slide is probably a few years old. I'm sure there's more now, but there are quote unquote stem cell clinics throughout the United States and actually around the world. Stem cell clinics in quotations, because a lot of these clinics, and not every single one of these clinics makes outlandish claims. Not every single one of these clinics has unproven treatments, but almost every single one of these clinics does not have FDA approval to treat patients. Most of these are for-profit centers. I mean, fees upwards of $30,000 for a single treatment. It is expensive to do this right now. There's no insurance coverage for this. When you see the facilities that Dr. Harman has, I mean, these are incredibly world-class facilities. It is expensive to process these cells, there's no question, but it certainly shouldn't amount to something like this. A lot of these companies have offshore injection sites, Cancun, the Caymans, Dubai, goes on and on. A lot of times you have unskilled and untrained providers. And really, that's when I got involved with the NFL alumni to really sort of stop this barrage of marketing to our membership. Um, let's talk a little bit about the history of VetStem. I mean, this is where PSC came from. Almost everything that we have done in medicine has started in an animal lab. They've been tested on animals, efficacy, safety, and then you move on to the human model. Dr. Harman's group started in 2002. They were the first commercial veterinary mesenchymal stem cell provider. They showed early on high improvement rates and mostly treated equine and canine. We're talking about high functioning horses, high functioning canines, military dogs, show dogs, thoroughbreds, racehorses. And they showed early on that these treatments were safe. It was a minimally invasive procedure to take the fat out. And they established real early credibility and market leadership. But that's not where they stopped. That VetStem engine started gearing up, and they developed clinical trials, double-blinded, placebo-controlled trials, which is the gold standard. We use the term RCT for these. Strong scientific validation. Dr. Harman is very well thought of in the FDA. This is why he was allowed to get into the human space. They have exclusive intellectual property rights to a lot of these early mesenchymal stem cell patents that they own. They were able to scale the fat in, meaning a physician or a veterinarian harvests a small aliquot of fat, and there's a proprietary way of shipping it over to his lab, and then having cells shipped back. It's a great workflow product. To date, I think actually more than this, 17,000 plus treatments with measurable outcomes. They keep the data on every single one of these patients that they've treated. So there's an evolution, a natural evolution from this animal model, these animal treatments over 30 years into the human space. He was encouraged by a lot of us to take his knowledge and his passion actually into the human space. And PSC was born. Personalized stem cells applies VetStem's proven model to the human space. It's autologous, meaning they use your own cells to treat you with incredible FDA clinical oversight. Of course, this is built on 20 plus years in the veterinary world, real world success and safety. It really was the natural next step in regenerative medicine. Some of the early studies, and not some of the early studies, some of the recent studies have shown that the fat-derived stem cells, these are adipose-derived stem cells or stem cells from fat, which contains more stem cells than almost any tissue in the human body, that, for instance, adipose-derived mesenchymal stem cells were the most effective treatments compared to mesenchymal stem cells from other tissues. The effect meta-analysis showing that adipose tissue was superior to bone marrow in terms of stem cells. Comparing umbilical cord Wharton's jelly-derived stem cells to adipose-derived stem cells, the adipose-derived stem cells were observed to be greater than the efficacy of the other treatments. There's really no comparison at this point. Interestingly enough, and I have not studied this, in all the publications that I've done, we didn't look at cartilage growth. We were solely looking at pain reduction and improvement in quality of life. But this study out of Seoul, Korea, an orthopedic department, really looked at proof of concept of injecting adipose-derived mesenchymal stem cells into the knee joint in particular, and showing damaged cartilage, and a year later showing healed cartilage. I mean, this is really an ongoing focus for this type of regenerative medicine, and there's more to come on that. So very simply, what do you do in PSC? Well, wherever you are, wherever you happen to be, there's a physician that you speak with that can harvest a small aliquot of fat tissue. And this is actually from a paper that Dr. Rogers did. It was a review of the literature. And a small aliquot of fat is harvested. And again, there's a proprietary way to ship it over to Dr. Harman's labs in San Diego. They are processed in the lab, sterilized. I mean, they are not sterilized at all. They're actually checked for sterility and for viability and the numbers of cells in each vial that they ship out. And those get sent back to your physician who has aligned themselves with PSC and is doing things the way PSC recommends and uses ultrasound to find the joint space, find the tendon, find the soft tissue injury, and inject directly into that space. I mean, the outcomes were pretty spectacular. WOMAC improvement, the V.A.S.S pain relief. These are scores that are used to identify improvement in the musculoskeletal system, and tremendous safety profile. The number of cells matters. So if you get a bone marrow aspirate injection, yes, there are stem cells in there, but there's not that many. There's just not that many. Wharton's jelly has basically zero. PRP has zero. Stromal vascular fractures, as I said, about 5 to 15% of that concentration are mesenchymal stem cells. But with culture expanded stem cells alone, I mean, you can get millions. And not only that, they can be stored and you can be re-injected without harvesting more tissue. It's an incredible journey. This is essentially how the procedure works. It's a small fat harvest. There's a secure chain of custody shipment to his FDA registered, it's a GMP compliant laboratory. Your own cells are cultured, they're expanded, they're checked for sterility, they're checked for viability, the number of cells that are alive, and the number of cells that they're in that solution. They're prepared and they're shipped back to your physician who, again, using PSC technique, ultrasound guided injections, and then followed by a rehab plan specifically for you. The fat is harvested by experienced surgeons. I won't belabor this point, but this is a very, very minimal amount of fat. We're talking about a tablespoon of fatty tissue to 3 tablespoons of fatty tissue, anywhere from 5 to 20 grams. And the work that a lot of us have done clinically, it's required somewhere between 50 to 300 grams for some of the other techniques.
So, Dr. Garza, let me interrupt you for just 1 second because you brought up a couple of really interesting points. One of the reasons we have you here and we have Dr. Rogers as medical director here is we want any physicians working with us to be properly trained. One of the reasons you're on board is to help us with these outreach training programs. Every single physician in the U.S. that we work with have been vetted out by Dr. Rogers, and in particular, so that we know that they're experienced in this ultrasound injection technique. Because harvest of fat, although for a plastic surgeon, it's standard of care. We don't want somebody way out of their realm of practice doing that. So I don't know if you have additional comments, but I think it's important that people know not every physician that's out there offering these kinds of biologics has been appropriately trained and is in their specialty.
I'd like to just make one quick comment as a clinician. I advise my fellow clinicians that stem cell is not a product. So many patients will travel overseas, go to a clinic, and essentially purchase stem cells, and they may or may not be getting stem cells, but at least that's what they think they're paying for. Stem cell therapy is a service, just like any other medical procedure or medical treatment, which includes an accurate diagnosis by a physician who's trained to diagnose and manage the condition. In other words, I'm in orthopedics. I'm not going to evaluate cardiac issues or pulmonary issues because that's not my training. Each physician should stay in their lane. The second is you have to have an intelligent conversation with the patient to explore their options, pros and cons. If you're going to do stem cell therapy, there needs to be an adequate product with adequate dose, and then it has to be properly administered, as Dr. Harman just said, with some kind of image guidance. I'm surprised how many clinics do not use ultrasound or X-ray guidance for their injections. And then finally, the patient will need additional treatment. They may need physical therapy. They need additional adjunct care. So stem cell therapy truly is a comprehensive service that should be managed by a team that's dedicated to providing that service.
Yeah. Thank you, Dr. Rogers. Thanks, Dr. Harman.
Yeah.
Continuing, so an FDA approved clinical trial that was performed by Dr. Rogers as a medical director of PSC. Again, the same technique. Here is the box that arrives into the injecting physician's office. The fat's already been harvested. The fat's gone through the processing at the lab. It is packaged, temperature controlled. I've seen these packages. I've worked with them. And this is the vial. This vial has not been sterilized. It is processed sterilely and injected sterilely in here. So these are living cells. I hear so many times from my colleagues that, well, I injected some stem cells. This company had them. They had a vial. They gave it to me. It's off the shelf, and they were sterilized. Well, we all know as physicians that sterilization means you're essentially killing every living organism in there, bacteria, viruses, human cells. And essentially what you're injecting is debris or fibrous debris. But the cells are drawn out of that vial and then under ultrasound guidance injected into wherever you're injecting it. And this is what it looks like. This is the vial. It's a pharmaceutical grade product. They're culture expanded. They're autologous. I mean, they are yours. There is a standardized dose. I think, correct me if I'm wrong, Dr. Harman, I think there's 15 million cells per vial, or is that that's the storage? I mean, that's the
yeah,
vial.
we put about 18.5 million in. The average coming out is 15 million for the patient.
So you're assured the quality of the cells, the potency of the cells, and the purity of the cells, and as important is the sterility of the solution. I mean, what are the expected benefits for people out there who are in the audience that are looking for something? It's essentially what you can expect is what we're looking for is less pain, improved mobility, and really slow that arthritic process. This was from Dr. Rogers' study with PSC. And what these terms are, they're all part of what's called the KOOS score. These are daily activity, pain, symptoms like catch and lock symptoms, pain symptoms, grinding, participation in sports, quality of life. And you see that there is an uptick at even lasting out to 2 years using this treatment. And you just don't see this in the literature very often. And mostly because the FDA hasn't allowed many of us to use these types of cells for these types of treatments. Excellent safety and tolerability. Again, approximately 74% of the patients had clinically significant improvement at 3 months. And those benefits persisted out to 2.5 years. That's incredible. And this was with a single dose. Satisfaction scores, which again are important. Almost 77% were satisfied with their treatment. Almost 80% avoided joint replacement surgery completely. 83% of them who required surgery after a year for whatever reason, whether it was an arthroscopic surgery or Baker's cyst, whatever it happened to be, stated that they were satisfied at their 1-year follow-up with the results. And what's important here is that repeat treatment may be helpful. And this is where the science of figuring out how to bank your cells so that when they're thawed out, even years later, they're viable. They're just as potent as they were when you put them in the deep freeze. A lot of that work came from VetStem, who did the exact same thing with the animal cells and thawed them out years later.
Can I just add, Dr. Garza,
Absolutely.
that 2.5-year point is just an arbitrary point at which I decided to have our research team call the patients and check on them and see if they were still satisfied. We are now almost 4 years out from initiating that study, and many of those patients are still doing well. So that was just a time point that we arbitrarily decided to check on patients at 2.5 years, but there's good evidence from our data as well as other published papers showing that patients in general will achieve at least 2.5 years of relief from a single treatment.
Yeah. Thank you, Dr. Rogers. One thing I forgot to mention at the beginning of the talk is that just as a disclosure, I am not getting paid to give this talk. I'm not getting paid to do this. I
I'll take
want
you to lunch. I'll take you to
everybody to know.
lunch.
So what makes PSC special? Again, Dr. Harman and his team, the work that they've done all these years, the wonderful work they've done for our animal friends, has parlayed that into an FDA approval to start working on humans. There is, and Congress passed this. This was not an FDA act, but it was a congressional act that the FDA has a hand in, and it's called the Right to Try Act. And this came out after the Cures Act that started back in 2017, I believe, 2017, 2018. But Congress just said, if there is a treatment, a pharmaceutical treatment, a drug of some sort, and has already gone through phase 1 clinical trial, which means safety testing, and is proved to be safe, and somebody that has either life-threatening disease or chronic debilitating illness, which is a severe joint, end-stage osteoarthritis, or a joint that needs a total replacement, who have exhausted their approved options. It means enough steroid injections, enough PRP, nothing's working, rehab's not working. They qualify for this right to try trial that PSC is involved in. What it does is it requires a willing treating physician, so your physician, your orthopedic surgeon, your physiatrist, and a willing manufacturer who is PSC. FDA review and IRB approval for this particular treatment are not required. However, the FDA does require an annual report from the manufacturer of the cells, the number of cells that were sent out, the doses, and that type of follow-up. And then again, availability depends on the sponsor's policy, their supply, their risk management. It's not a blanket approval for clinical marketing. You start doing right to try, that doesn't mean you put up a big website and you start marketing your practice. You're just going back to what it was before. This is not that. The products have to be manufactured under GMP compliance standards, and they have to have completed at least a phase 1 trial, which PSC has surpassed already. And they have to remain under FDA investigation. Don't let me forget to say that, because if a treatment, a drug, the FDA has stated that it can no longer be used, or it has put a halt to it, it cannot be used in the right to try. There is another avenue called expanded access that the FDA has a lot of involvement in, but the right to try trial proceeds directly between the patient, his physician, and the manufacturer, who is PSC. This was really interesting, and I sat in on this wonderful talk by this wonderful athlete, Erin Taormino. Erin Taormino lives in Texas, and she was the first female who was voted Horseman of the Year. An incredible rider, and incredible stable of horses. Well, one of her horses became lame, and she, through contacts, found out about VetStem and referred the horse through her veterinarian to Dr. Harman's VetStem lab. That horse was treated. That horse went back to full competition. This was a horse that was going to be put down. Went back to full competition. This young lady, I don't know if it was in the year or not, Bob, you can come up with the rest of the details, but had severe bilateral hip osteoarthritis from exactly what she's doing here. Years and years and years of riding horses. And she was not going to be able to ride anymore. And so she made an inquiry, and PSC had just been formed or been approved by the FDA. And she had both hips injected with PSC and went back to riding. She gave an incredible talk. It was very, very moving. But she was one of the early right to try case studies, and Dr. Harman, how many have y'all done now under right to try?
We're over 100 now total patients, and mostly in orthopedics. Again, that's our focus right now. We will get there. As you know, we're working on a traumatic brain injury protocol to submit to the FDA before the end of the year and try to next year get into early work doing intravenous administration for traumatic brain injury, which is rampant in our athletes, including, by the way, these patients that are riding horses. There's lots of brain injury that happens there. But she was truly facing bilateral hip replacements, which would have taken her out of her sport.
Thanks. So I want to mention that that stem cell banking program, it's called STEM Insure, and I think Corbin or Dr. Harman will elucidate on this a little bit more. But essentially, if somebody's not ready for a treatment, they're young, or even if they're old, uh, a simple little fat collection procedure, they will process them, get a pharmaceutical grade stem cell product, put the vials away for you, and they're going to be stored in an FDA registered and a federally licensed tissue bank. This is real. This is essentially what they're stored in over here. The cells, really, this is incredible. Again, this came from the early vet stem studies. The cells remain at their current age. So if you're 35 years old and you've got your cells banked, they're going to be 35 years old when you're 70. They maintain their age and their health for decades. Again, this has been proven, it's been published, and it provides virtually an unlimited number of treatments for future use. So it may get to the point where one of our clinical trials says, an injection a year after the first injection will give you an extra 5 years. That data is coming. So PSC, it's safe, it's personal, it's data-driven, and FDA trials are a major, major part of all this. It's about safety first. You use your own cells. Those of us who've played sports most of our lives, it was our DNA, our own makeup that powered our success. Why would I want somebody else's cells to repower that body or that engine? Why not repair with what already works? Use your own cells, your own DNA to heal and restore. I mean, this is truly elite biology. And stay in the United States for your treatment. Stay in the United States. So to learn more about treatments and banking stem cells, I'm going to turn it over to Corbin May. Thank you, Corbin.
Thank you, Dr. Garza. Again, I will invite anyone, if they should have any questions for Dr. Garza, Dr. Rogers, and Dr. Harman to open up the Q&A section underneath your Zoom panel, and you can type in some questions. I know Dr. Rogers and Harman have answered some questions in there, but we'll also bring them up for some of the discussion topics here shortly. I'll let you do that. Once again, you can visit our website, www.personalizedstemcells.com. Following this, if you wish to pose any questions for me around stem cell banking, you can talk to a PSC expert and you can schedule a call. As I've reiterated, I am available as early as 9:15 a.m. Pacific time tomorrow. You can download our ebook. And if you're interested in learning where a physician that is PSC affiliated and has gone through and been approved by Dr. Rogers and our medical team, you will see the different physicians that we work with in the different states as well. So opening up,
Yeah.
sorry, go ahead, Dr.
The most obvious question that always pops up in every single webinar we do, somebody says, hey, I'm 70, are my stem cells too old? And I've heard Dr. Rogers answer this like, I don't know, 1,900 times. But it's such an important question because somebody will say, oh, I should use some young umbilical cord cells because I'm too old. My cells are worn out. How do you answer him, Dr. Rogers?
I have a couple of answers to the question. The first is, regardless of what makes common sense, to me, it would make common sense that brand new baby stem cells would be superior to my 61-year-old cells or somebody's 85-year-old cells. However, if you read the clinical trials, you will see that that's not the case. You will see that again and again, your own adipose-derived stem cells, and I'm talking specifically for orthopedic conditions because that's the area for which I focus. Your own cells continually outperform the umbilical cord blood studies, the Wharton jelly studies, other perinatal tissues, placenta. So the first answer is, if you're looking at published clinical trials in medical literature, you will see those results again and again and again. The second answer is, if you're going to the doctor on the street corner in the United States of America, and that doctor is offering you umbilical cord cells or Wharton's jelly cells, just kindly say, no, thank you. Not only because they're inferior in clinical trials, but the product that they're offering is an illegal product. The FDA has not approved that product for use. And as Dr. Garza said earlier, it's highly probable that there aren't any living cells in that product at all. So
good.
It's not allowed and it doesn't work.
Great. Dr. Garza, you got involved in fat very early on in your career, and as a plastic surgeon, you handle that tissue. I think people might be interested in the story of how the stem cell in fat was actually discovered, and the power of cells that are in fat.
Well, my story is, I was at the University of Pittsburgh is when I was first exposed to this. I was training in the early 90s, late 80s, and liposuction was a brand new technique. Dermatology had been using it for a couple of years, and plastic surgeons said, let's get involved. Our illustrious chairman at the University of Pittsburgh said, I'm flying somebody from Brazil, because in Brazil they were doing a lot of liposuction, and we learned how to do liposuction. Two of my junior residents were in a room with me, and we were liposuctioning a patient, and we had canisters of yellow fat just sitting there, and our chairman walked in and asked us what we were doing and what are we going to do with that yellow fat. And the answer was, stupidly, one of them said, we're going to throw it away. What do you think? And he went crazy and ran him to the research lab for 6 months and said, find something to do with this. And really, there had been some early work going on, I think, on the West Coast, down in San Diego as well, with you and your group. And really, it was just sort of all the satellites pointing in the right direction. And it was discovered that these progenitor cells, we used to call them pre-adipocytes, were actually mesenchymal stem cells. It was really incredible. And then the amount of stem cells that you find in an aliquot of adipose tissues compared to other tissues is phenomenal. There's 500 times more stem cells in an aliquot of adipose tissue than bone marrow. And that's been published and proven time and time again. Not knocking bone marrow at all, but many, many more cells.
I think the point you're making is an important one about the bone marrow, because I'm in orthopedics, non-surgical orthopedics, and offered bone marrow aspirate concentrate as a treatment for many years. This is about 12 years ago, 15 years ago. And we saw some good success, but it wasn't predictable. And I think it's a mistake to call that a stem cell therapy, as you point out, simply because on a good day, if you aspirate 4 tablespoons of bone marrow, you'll get about 50,000 cells for the same volume total, right? For the same volume, the 4 tablespoons of fat, you're going to get about 1 million stem cells. So significantly greater number of cells. That's important because, as you said, dose matters. The studies that have looked at the treatment of knee osteoarthritis, the studies that have looked at treatment of rotator cuff tendon tear are starting to show that higher doses are producing better effects than lower doses. And it makes sense that there would be a dose effect. So the treatment's only going to be effective if it's dosed appropriately.
Yeah, and in the veterinary data, it was fascinating because we were asked to treat old dogs. And I go, okay, are their cells any good? And lo and behold, when you extract these cells from fat, not bone marrow, old dogs and old horses have no stem cells left in their marrow that are these kind of mesenchymal stem cells. They're gone and they're old, they're worn out cells. They don't grow very fast. But from fat, even in the oldest animals, we saw them really robust growth. And so when we did our human study, the oldest patient, I think, was 92 years old. We extracted their fat, cultured cells, and beautiful cell growth. For some reason, Dr. Garza decided he was going to work with fat for his career, and it turns out to be the most spectacular. Fat is beautiful. It's an amazing tissue that's usable for all this kind of healing. And little did we know in the 80s that we were going to be using this as a biomedicine.
Yeah.
I know I was blown away when I first learned it as well. We've since learned that it's really not about the tissue, it's about the vascular
Yeah.
density of the tissue. As Dr. Garza showed you, those little cells live on the microvasculature, and wherever you have blood vessels, you're going to have stem cells. And why wouldn't you? That's what your body needs to do the repair. So
Yeah.
the system makes sense.
Yeah.
One of the common questions we get is, what can you treat? What are your
Mhm.
outcomes like? So if anyone in the audience wants to type in there at the bottom where it says Q&A,
Yeah.
type in your question. Somebody asked about osteoarthritis of the glenohumeral joint. We treated a number of patients.
Which is shoulder, yes?
Shoulder, sorry, yes, shoulder joint. Yeah. In the, what's it called in the dog or horse?
It's a shoulder. So
Shoulder.
medial shoulder instability is rotator cuff in the dog.
Okay.
And
In the
so I'm
knee is
just
a
like a dog with
stifle.
my rotator cuff.
Yeah. I think that in a dog or a horse, the knee is a stifle joint.
Right.
So,
Yeah.
but more similarities than differences, I guess,
Hmm.
between the
Yep.
species, but including how the cell functions in different
Yep.
species. Well, I think I've heard you say more than once, very well conserved mechanisms throughout multiple species, which is amazing. But our focus is primarily on orthopedics because that's where most of the published clinical research
Yeah.
is. We're practicing evidence-based medicine. We're using the published scientific papers from around the world to guide our treatments. So it was a no-brainer really to start with knee osteoarthritis because that's where the lion's share of the published clinical trials had been performed. And
Including Dr. Garza's trials, several of them
yeah,
in knee osteoarthritis published as well.
Dr. Garza needs a shout out here. He's, I believe, the first U.S. physician to conduct an FDA-approved clinical trial using stem cells from humans in
And
orthopedic applications. I believe that's true. So, we need more scientists to produce work like this. We have also treated other joints in the body. So, shoulder is a very common joint to get arthritis. The hip, the thumb, believe it or not, right where the thumb attaches to your wrist, that's a common place for people to develop osteoarthritis. We've also treated a number of tendon conditions, rotator cuff tendon, tendon in the hip, Achilles tendon, and then the spine, which has been my focus of attention for the last nearly 30 years. Back in the 90s, I would inject cortisone into joints. I would inject cortisone in the epidural space for sciatica. We would even inject into the disc. And now instead, we're choosing to inject cells. And it's still early. There's not a lot of published literature on injecting the disc, but the early studies are showing good outcomes. And this is really the holy grail because I think everybody realizes how common
yeah.
chronic back pain is.
Hey, Dr. Garza, you've been involved in some of the big studies for NFL players and other sports. Those kinds of studies and academic center studies, how do you see them interfacing with the kind of real world data we're starting to get and bringing those people together? You clearly have bridged your career with academic career and clinical career in the field.
Well, yeah, thanks for that lead in. I think the leading experts in the study of NFL players is really the Harvard football player study.
Yeah.
Dr. Grashow, Dr. Adam Tedford. I mean, they're just doing remarkable work. I was actually one of the early
Mm.
signees for that study. I signed
Yeah.
up for it close to a decade ago, I guess, maybe 8 years, something like that. But the data that's coming out of there is really pretty spectacular. But it's really interesting to note that that is a very unique cohort of patients. I mean, there is just a constellation of maladies that sort of play off of each other. Hypertension, concussion related hypertension in basically young men, in their late 30s. Knee osteoarthritis, ACL injuries and cardiac disease. I mean, I don't know how that's going to translate to real world, to be honest with you, but I think I'm really kind of happy to say that the great work that Kyle Richardson and his team are doing at NFL Alumni Health, we've built some great bridges over to Harvard and also over at my alma mater, Tulane, at their Center for Sport, um, trying to bridge that gap between the science and then the real world stuff with our current players, or our current ex-players and current membership.
So again, I'm just a veterinarian, but I have seen a ton of hamstring injuries in quarter horses and thoroughbreds. And up until about the last 5 years, nobody put stem cells in there. Now we have data, in fact, from the veterinarian that treated that horse you showed earlier, has treated lots of hamstring injuries. How do you see it working in that kind of a muscle related injury in NFL players? Well, actually, all the athletes get hamstring tears.
Well, I mean, that's more Chris Rogers' field of expertise. I'm familiar with doing hydrodissection using that dextrose solution. I think they use that a lot
Yeah.
at the institute, one of the institutes that I'm at. But I'll let Chris answer that. What are your thoughts, Chris,
I
on
mean, I
soft
have
tissue injuries like that?
um, there needs to be more published clinical trials, but I can tell you the anecdotal experience from myself, my colleagues, including colleagues at Mayo Clinic, some colleagues at Harvard, at Spalding Sports Medicine. We are shocked at how well adipose tissue works at treating significant tendon injuries specifically. I treated my first Achilles tendon injury, I want to say maybe 10 years ago, using just simply adipose tissue that had been minimally manipulated and processed in the office. There's actually some published data on, you talked about stromal vascular fraction, which is a fraction of the adipose tissue, some cells showing very good efficacy for chronic Achilles tendon injuries. One of the attendees today is asking about chronic Achilles tendinosis. Platelet-rich plasma has been shown to be very effective for that as well. But certainly for those that do not respond to conservative care, consideration with culture expanded cells makes a lot of sense. Maybe that should be another lecture. We did a little presentation to our physicians last night, our advisory board, and presented some literature on that. There's some good basic science on how stem cells can be involved in healing tendons in a variety of different ways, and the clinical outcomes are matching our expectations. We have a number of questions, folks, we should probably attend to here.
Dr. Rogers, a lot of
Hmm.
the questions are really centered around spine and
Yep.
yep, and degenerative disc disease, and certainly some neuropathy related back to that as well. Again, somewhat of your anecdotal experience. Do you mind sharing some of that in relation to what you're seeing with spine and what we're hoping to achieve there?
Yeah, I have very strong opinions around the spine. I've been treating the spine since 1997. I did my fellowship in interventional spine care, where I was trained by Dr. Dreyfus, who is a giant in the field in non-surgical care of the spine. I was very fortunate to work with him. And like I said, the first 10 years or so after that training, we were pretty much just injecting steroids, but quickly realized that cell therapy would play a huge role as well. So I would say with our PRP experience, we were well in, we have a decade and a half years of experience using PRP for more mild osteoarthritis, for smaller disc tears, disc degeneration. For the more advanced disease, this is when cultured stem cells are necessary. Anything that PRP can do, I say culture expanded stem cells can do better. The response rate will be higher in the more advanced cases, more severe disc degeneration, more severe osteoarthritis, when you use stem cell therapy as opposed to when you use PRP. I've had a number of patients where they've been treated either by myself or elsewhere with PRP, didn't have the response they wanted. We then treated them with culture expanded cells, and then we get the outcome that we're looking for. So I just telling you from our personal experience, we are seeing that there's going to be huge potential in the spine. Now, I advise strongly that every patient seek out clinicians who are trained in their lane, in their field. I have seen websites from clinicians around the world where they treat everything from Alzheimer's to Zika. I will tell you, it's hard enough being good at treating the spine, let alone treating every other malady known to man. And that's because the most important step is an accurate diagnosis. And that requires someone who really focuses on your area of expertise, on your area of need. So for those folks who are dealing with disc degeneration, facet arthritis, maybe a pinched nerve, sciatica, spinal stenosis, these common conditions we see in the spine, seek out someone who has, my training in physical medicine, or an orthopedic surgeon who specializes in the spine, perhaps a pain management physician who specializes in spine care as well. But a general physician is not going to be able to provide that level of service. I have personally, someone's asking about spinal cord injury, obviously, devastating injury. There has been published research on the use of culture expanded stem cells for use in spinal cord injury. The most impressive results that I've seen were done out of Mayo Clinic, and that was done under our friend Dr. Wenchen Yu, who's now at Mayo Clinic in Jacksonville. So I personally don't treat spinal cord injuries. It's not my area of expertise, but I do refer them to my friend who I trust and who has an FDA-approved clinical trial that he's conducted. I met a young man. I personally have met patients who were treated who, for example, one young man in his 20s, Bronco bull rider, where this is going, fell off the bull, broke his neck, quadriplegic. I wept when I heard his story. This man could not use his hands. He was wheelchair dependent for the better part of 9 years. He did have treatment to his spinal cord injury and recovered much of his function in his hands. I had never seen that before. I'd never heard of anything like that before. However, I would caution that optimism with the reality of the challenge that healthcare and medicine is facing. So you really need to seek out the researchers who are focusing specifically on that. I would caution patients to not necessarily travel overseas. You're not going to find that level of service, I don't think. I have not seen it yet.
Yeah. And you can go to clinicaltrials.gov and you can type in spinal cord injury stem cell, and you'll see the universities doing the top work in those. Spinal cord is really difficult. Alzheimer's, Parkinson's, it's a very difficult neurodegenerative diseases, and there are clinical studies going on, but we've got a ways to go with those. In the area of orthopedics, we have a huge amount of data, hundreds and hundreds of papers published, not just here, but worldwide using these kind of technologies. And every time we consider as a company what we might want to treat next, we look for data. Dr. Garza and I have talked about concussions and brain injuries for 10 years now, maybe? And in fact, one of the top researchers in the country is Dr. Charlie Cox at University of Texas, Houston, and he's now done 2 clinical trials. It now has led us to believe we could consider that for this next year because there's beginning to be enough real data. But some of these companies, particularly overseas, you have to ask the question. And by the way, if you want to know the 21 questions to ask any stem cell purveyor, you can connect with Corbin, connect on the website, and we'll email you that list of the questions you should ask. And most of these inappropriate and illegal locations won't answer, can't answer, or if they did, you'd run away. And so it's good to have those lists so you can ask somebody. And there are some of them in the US too. They're really inappropriate. LA, there's 3 of them that should be shut down by the FDA. Dr. Garza, I know, sees them because they come knocking on the door of the NFL alumni trying to hawk something. Make sure you get your questions and ask the right question. These cells are not magic, but they have spectacular potential for the future. Some things we know a lot, other things we don't know enough. And we will continue to do these kinds of webinars on different topics as we go forward, for sure.
The success rate is really what we're measuring and what other clinicians are measuring around the world. And that testimonials, somebody's asking about testimonial. In my opinion, testimonials do not replace published clinical data. The published clinical data is subjected to public scrutiny and professional ridicule. So with Dr. Garza, Dr. Harman, Dr. I stand on the podium at a medical conference, our physicians can throw darts at us and attack our scientific method. And that is the healthy process that needs to happen to have true, evidence-based healthcare. Testimonials are not evidence-based healthcare. Having said that, now almost 30 years in clinical practice, culture expanded stem cells are by far the most powerful treatment in my toolkit. They're not for everybody, but they have helped many of my patients. Knee osteoarthritis, I think, is an area that I could confidently say we have very high success rate, in the high 80s. Success being defined as a year later, the patient is still satisfied that they had treatment. And most importantly, it's safe. Using our own cells, we've had no serious adverse events. We report every year to the FDA, and fortunately, we've not had to report any serious adverse events. There have been, I've read and I've heard from patients, there have been cases of patients traveling south of the border, getting infections in their knee, ending up with septic or ending up with sepsis, ending up in the hospital. So I just caution people to be asking all the right questions when they seek out this care.
Wonderful. And I want to be really respectful. Dr. Rogers probably has another consultation coming up here as well and needs to go save lives, I'm sure. I want to be really respectful of everyone's time. Of course, some of the things that we implore you are number one is getting your stem cells collected. They're never as young as they are today. If you are interested in some of the individual questions getting answered, I know there's a lot of individual questions. In order to be able to do that successfully, you really do have to have a correct diagnosis, and that really does require a consultation. If you're interested, Dr. Rogers has consultations, and we can expedite you as a PSC interested patient here. And so again, I would once again encourage you to head over to our website and book some time with me. I'd be happy to discuss our stem cell banking program. I'd be happy to answer any of the questions as best as I can. Once again, in sharing my screen, talk to a PSC expert, and you can speak to me again as early as tomorrow. Somebody has already clearly taken my spot for that 9:15, but you can catch me at 10 a.m. Pacific, and we can talk about cells, and I can see if you can get a consultation with Dr. Rogers there as well. So thank you to Dr. Garza, Dr. Rogers, and Dr. Harman for their time on this. Again, we have recorded this, and we will send you out with a recording so that you can review it. We know we covered a lot of information there. So thank
Dr.
you.
Garza, any final thoughts from you? You've been around this field for a long time now. Not saying you're old, because I think I'm a bit older, but you've been around this field and seen a lot of things come and go, including the big Harvard study. And any last thoughts?
Yeah, I just want to reiterate what I said about my belief that, I've been waiting 18 years, 20 years for FDA to allow this to happen in the United States under the right conditions. And certainly we're at an inflection point. There's no question. We're not quite there in terms of this treatment being available to everyone. But for me, my ex-NFL brothers and sisters too, because the cheerleaders are part of the NFL alumni, this one was for y'all. We're looking for help. And we just want to make sure it's the right kind of help and that no harm comes to anybody that gets treated. So thank you. Thank you all for the opportunity, Dr. Harman, Dr. Rogers. I appreciate it.
Thank you, Dr. Garza. Appreciate it.
Thank you.
Thanks.
Thanks, everybody.